my name is Lisa Gall. I'm a Quality Improvement Advisor at Superior Health Quality Alliance. I'm thrilled to welcome you and to present the instructional video for the HAT and his tools to help prevent readmissions. Home care acceptance tracking after implementing home care intake scripting. This presentation will show you how to track home care acceptance rates after implementing an intake scripting tool with the goal of reducing hospital readmissions and unnecessary overutilization of emergency services. This module is provided by Superior Health Quality Alliance. Contributing to this video is a demonstration of the HIS tool by our project lead and quality improvement advisor, Barb Link from Superior Health Quality Alliance, along with project participants from ProMedica, Home Health and Hospice, Administrator Aaron Crowley, and Account Liaison Kara Diaz. Upon completing this module, the learner will be able to learn the importance of timeliness of care and how it relates to reducing emergency department overutilization and unnecessary hospital readmissions. Understand and implement a home care intake scripting or HIS tool and intervention within your agency's intake process. Monitor the effectiveness of the HIS tool on home care acceptance rates using the Home Care Acceptance Tracking or HAT tool. Learn how to track and submit data from the HAT tool to Superior Health Quality Alliance and compare your home care acceptance rates to other home health agency participants. This slide highlights the studies that determine the percentage of readmissions and associated costs. Randomized clinical trials estimate that the rate of preventable readmissions in the US is anywhere between 12 to 76%, with nearly 20% of patients 65 and over discharged readmitted within 30 days, costing over $1.9 billion annually. While some readmissions are unavoidable and result from inevitable progression of disease or worsening of chronic conditions, a fair number of readmissions may result from poor quality of care or inadequate transitional care. These studies are showing that the readmission rates decrease with improved health care in all of these areas. We will be focusing on coordination of care after discharge, in particular home health agency services. Superior Health convened a work group consisting of over 20 home care agencies from Minnesota, Wisconsin, and Michigan. The ultimate goal was improving home care acceptance rates and timeliness of care. Our data analysts were able to uncover some limited but interesting facts from Centers for Medicare and Medicaid Services. For example, readmissions increased if patients were admitted to home care on Thursdays, or if they were not accessing home care timely. We held lengthy discussions with our home care work group regarding barriers and gaps, including both access and knowledge gaps affecting the delays in initiating those home care services. As we shared the data with and between the home care work group, it became evident that the intake process is a vital area for initiating timely home care services, and that many reasons care was not initiated promptly. Some were seemingly unsurmountable, such as staffing during and after COVID, and competing priorities such as healthcare appointments or family or caregiver availability. The work group decided to focus on the other reasons for declining care, such as patients' lack of knowledge, having specific concerns, or they weren't feeling well. They provided input for the development of a home care intake scripting tool to be used during intake. The HIS tool provides cues for intake workers to address the most common reasons for declining a visit. Superior Health then developed the home care acceptance tracking tool to support organizational data collection and to determine if implementing the home care intake scripting tool actually improved the acceptance rates. Besides monitoring the home care acceptance rates, It also tracks training and use of the home care intake scripting tool and reasons for declining services. As with any good project, we recommend identifying the assessment, plan, implementation, and evaluation phases during your project, and using a PDSA or Plan, Do, Study, Act cycle after implementing it. The assessment phase helps you identify who to train in your organization on the tracking and scripting tools. You may decide to only train one intake worker on both tools, or to add backup staff or new staff. You may decide to have everyone involved in the new verbiage for consistency between intake and assessment staff. And you can include more staff whenever you desire, especially those who might have the first direct contact with the patient. In the planning phase, assigning roles and responsibility so things don't get dropped is important. Involving your leadership and intake staff, figuring out who holds overall responsibility for things, like who will submit the data, who will analyze it, what will you do with the data, and who decides if and when changes might be made. Also, determine who is responsible for maintaining the documentation and communication with everyone. So you want to determine who you want to complete the video training, and how you will know that training has been completed. This is important because the baseline and initial data submission depends on the date of the in-service. Baseline data is submitted within 10 days, and you will submit data on a monthly basis before the 10th of every month. The form is very easy to use. Literally, you just email the form to Superior Health Secure email in a secure email, and remember that you should not include any protected health information. The implementation phase is having your intake or other staff watch this video. The very next day, they begin using the scripting tool and documenting 3 things. On the HAT tool, if scripting was used, if they accepted home visits, if no home visits were done, why not? And it also provides the opportunity for staff feedback and fosters collaborative thinking to help identify what works and what doesn't. During the monitoring or evaluation phase, the HAT tool will monitor acceptance rates and the use of scripting. You will then be able to evaluate trends and issues and generate ideas and improvements. And using the PDSA cycle to decide if and when to implement changes. The first step is to enter baseline data. This screen shows the the home care acceptance tracking or HAT tool. And most of the data in the HAT tool populates automatically after you fill in the yellow highlighted cells. You'll begin by filling in baseline data and in-service dates. Shown in the upper right-hand corner, you'll enter the number of intakes in your baseline period using the longest time frame possible to compare to the new data that you'll be collecting. We recommend at least a 4 to 12-week period to use for your baseline data collection period. The baseline period ends the day you view this video, and implementation begins 1 day after your first in-service. Those dates will automatically populate when you enter your in-service dates. On the far left, you will enter your intake service in-service dates, the number of attendees, and the number of staff you plan to train. And if you have additional in-service dates, you put it in the light gold areas below that bright gold initial in-service date. This is an example of a completed baseline in data form. On the top right, you can see that 47 out of 100 accepted home care services for 47%. And then below the initial intake data is pulled from the first monthly intake form. This will be shown weekly for the first month, then monthly thereafter. On the left side of the form, you can see there were 4 in-service dates with different staff, and that the initial, this agency added another person to their initial list of trained staff, totaling 11 rather than the 10 staff trained. The implementation dates are in the middle, and they correlate with the day after training. You can compare percentages later. I will show you that in the next screens. The second step is to educate staff and implement your intake scripting tool. The intake scripting intervention was developed with in collaboration with home care agencies in a root cause analysis of hospital readmissions, and we identified actionable interventions that might move the needle towards not only higher home care acceptance rates, but timely start of care with front-loaded home care visits to provide timely interventions for at-risk patients. The scripting tool offers 6 talking points for the intake call receiver in your agency. It can be an intake nurse, a trained support staff, or someone covering for them. You can include other nurses or professional staff, assessment staff, or support staff. The tool allows users to use their own words and language. It offers rationale for home care and the effect on the patient's health and well-being, in particular, decreasing readmission rates. It addresses client questions directly, therefore improving trust. It dispels myths about home care that can lead to reluctance. Staff should be reassuring rather than unsure if this is a good fit for the patient. It provides consistent and accurate communication by all staff and normalizes home care services as a component of healthcare. The first 2 points of the scripting intake tool covers an introduction and why home care is being recommended by their clinician. And there are some points in here on why the doctor feels it's important. For example, we want to make sure you're okay. They want you to get better faster, especially if you're not feeling well or having difficulty. And we can come to you, and if they're not feeling well, why not? Let's work together. So it's really a joint effort with the home care agency and the patient in their home so that they can get better quicker. The next 2 points of the script are explaining the payments and what will be done at the home care visit. And it gives some verbiage in there. Usually there's no charge for an assessment visits, the frequency of visits, how you schedule your visits, and how they can increase or decrease. And then at the assessment visit, the nurse will, or the therapist will do this or do that. So, and also assuring that they will notify the doctor if there are any concerns. And the last 2 points cover appointment scheduling and verification that the patient has a follow-up appointment. And this tool offers verbiage, but it's more of a prompt for you and your staff to cover those points, allowing you to use your own words and following your own agency protocols. The biggest points here to verify that there's a time, a callback number, and determining if the patient needs help scheduling an appointment with their physician, and prompt someone in your organization to help them if needed. That might be a nurse, that might be, support staff, whoever that is. These are examples as stated. And so now I'm so excited to show you this next video clip demonstrating the use of the home care intake scripting tool. Special thanks to our home care timeliness of care project participants, Erin Crowley and Kara Diaz from ProMedica Home Health and Hospice. And they demonstrate the use of the scripting tool with project manager Barb Link from Superior Health Quality Alliance.
Thank you, Lisa. Yes, my name is Barbara Link, and I am a quality improvement advisor with Superior Health Quality Alliance. I would like to introduce you to one of our home health agency work group members, Erin Crowley. She's the administrator for ProMedica Home Health and Hospice, and her coworker, Kara Diaz, who is an account liaison at ProMedica as well. So today, Erin and Kara will be providing a role play example for us. They'll be using the scripting for intake workers to improve acceptance of home care services, and then how that would work with a new patient. And then when we're done with that, we will show you how to actually track the outcome on the home care acceptance tracker of the role play that they've conducted. So at this point, I'd like to turn it over to Erin and Kara.
Hello, is Ms. Smith there? I'm Mrs. Smith. Hi, Mrs. Smith. I'm Ms. Kara Diaz. I'm a case manager for ProMedica Home Healthcare and Hospice. How are you doing today?
I'm doing okay.
Yeah, I heard from the doctor you just got out of the hospital, huh?
Yes, just late last night.
How are you feeling?
I'm not feeling very good. I'm pretty wore out from my stay at the hospital.
And you just tired and sluggish, or you have something else?
I just don't feel good. I'm just tired. My stomach doesn't feel good. I just want to rest for a few days.
Okay. And that's one of the reasons why your doctor wanted us to give you a call, because we want to get in there. He'd like us to see you within 48 hours of being home from the hospital.
Well, I don't know about that. I just got home. I really want to just rest and then get a few things done. So what is this home health?
What home health care is it's covered by your insurance. And basically, since you've had a hospital stay and then you went home, you've kind of gotten a little weak, and you said you're tired and a little sluggish. And that's what happens when you go into the hospital too, because you're not as mobile. So basically what home health care does is we can bring in a nurse, also physical therapy and occupational therapy. So we can help you kind of get back to your daily activities, to help you navigate around your home. And, what caused you to go into the hospital in the first place? Did you fall or?
Well, I did. I hadn't feeling good, and I fell down, and I had to call the ambulance and go into the hospital.
Is that something you'd like to do again?
No.
Oh, well, then I think that's another reason why your doctor wants us to get in sooner rather than later, because the longer we wait, the more opportunity is for you to not feel any better. You're not going to get better because you're not having that, you need somebody in there to help you out. You've been in hospital for so long, chances are within 24 to 48 hours, it could happen again. And we'd like to be in the home to take care of you. We're not staying for dinner, but
okay.
Okay.
All right. I would be agreeable to someone coming out and seeing me then.
Someone's going to be me.
Okay.
So how's your available tomorrow?
That'll work. I can make time tomorrow. That sounds good.
I will give you a call before I head out and let you know how I'm on my way.
Okay.
Perfect.
Thank you.
You're so very welcome. I'll let Dr. know. Thank you,
Okay.
Mrs. Smith.
Thank you.
Yep. Bye-bye.
Thank you so much. So when we think of this particular role play, the scripting was used and the patient did accept the service. So as you can see from the intake tracker in the role play, the patient was patient A2. Scripting was used, and that box was checked, and the outcome of the conversation was that the patient accepted home care services. At that point, that's all they have to do, unless the intake worker or staff member would like to provide more feedback or any suggested changes. But that is what that would look like for that particular outcome. So I want to thank Erin and Coda so much for providing the role play today. And now I will turn it back over to Lisa.
Thank you, Barb, Kara, and Erin. Step 3 is to begin data entry. That data entry begins the day after your first intake worker has been trained viewing this video, which means listening to this video and understanding how to complete the tool. The home care acceptance tracker is quite simple to use and requires really minimal input. I will explain these areas on a blank tool and then show you what it looks like completed. Every month of the tool has separate tabs for every month. You fill in the yellow highlighted areas indicated the month of the data, and then you complete the data on line 1, week 1 on the left side under date. This example shows week 1. There are 4 weeks in every month, obviously, but a little more than 4, but we have room for 4 weeks. Each week starts with a light gold cell, and you enter the date, followed by a non-identifiable patient ID or initials. Whether or not you used the scripting method or using the HIS tool. Documenting, did the patient accept home care services or not? And if they decline, it requires the use of a drop-down list on the reason declined. And there are also other reasons for open-ended responses. The staff feedback has a drop-down list as well. And there's an area for suggested changes. This area, your agency will determine who is responsible for completing that suggested changes. It may be a way to garner information from your staff or maybe your project lead. Here's an example of how the HAT tool may look after the first week has been completed, with date on the left, initials of the patient, whether scripting was used or not, and if home care services were accepted or not, all with an X. So it's either an X and no scripting, or accepted or declined. And if declined, the reason, there are some reasons given on here. I will show you that also on the next page. If there's not a reason, you can add some open-ended responses. Here are the reasons declined that are in the drop-downs. This is drop-downs for staff feedback, just to get a feel of how they're feeling about the scripting. And your organization can decide who can add comments under the suggested changes. And I think, it would really stress the creativity if you have everyone inputting into that area. Okay, this tool calculates a lot of data automatically, and the 4th step is to monitor the rates of the scripting use and home care acceptance. The blank tool shown here shows a compressed view of the 4 weeks in each monthly tab. As data is entered, it calculates in real time on the bottom of each page. I showed you week 1, it actually has the 4 weeks in here. And on the bottom of each page, it shows the calculations as you enter data in real time. You don't need to complete any data on the bottom here unless you want to manually, enter data in and do some specific comparison between whether scripting was used or not used and how it impacted your rates. And this shows the bottom of each page, which calculates the monthly data. This data feeds the monthly tracker, which I'll show you in a minute here. The first month has a weekly monitoring tool to quickly see how you're doing for scripting use rate and home care acceptance rates. If you're curious or want to do early PDSA, you can use the comparison tool, like I mentioned earlier, to show the difference between acceptance rates with and without the scripting tool. You just need to count up in the columns above how many patients who accepted had scripting and how many patients who accepted had no scripting. I'm assuming, though, that the majority will be using the scripting tool once they're trained. And then the results on the right side will calculate automatically if you decide to use that additional tool. So the monthly HAT data tracker, that's home care acceptance tracker, is where you will look for monthly comparisons. So for the month of May, as data is populated, once you put in your first month of data, all the rest of the months will come in automatically. So you don't need to complete anything in this tool. It just shows your results. It's calculated and compared. It shows the scripting use rate and the home care acceptance rate on the far right. And data on the bottom is all inclusive, showing total numbers and overall percentages. The next step is to submit this data to Superior Health Quality Alliance. And baseline data is due within 10 days of implementation. Again, that ends on the day you view this video. And then by the 10th of every month for the previous month, you should submit your data to the HAT tool at superiorhealthqa.org. The final step is the evaluation phase, where you can review your data, the staff feedback and suggestions, and initiate your own PDSA cycles. So you've completed a plan, you did the intervention, you documented it. Now you study it to see if there are any internal modifications to make it even better, or fix a glitch that you may have discovered. As participants of the Superior Health Quality Alliance work group, it's invaluable to bring your experiences and ideas to the team meetings so we can collectively learn from each other. The group will review staff feedback, consider it and if or how the scripting should change, and how to address barriers to initiating care for your clients. During the evaluation phase, use PDSA cycles to improve your internal process. And we encourage you to bring your feedback to the large group meetings. We'll never hold you back from making internal decisions and changes. But if, for example, if you want to immediately implement a change, you can do so. This is your project. You're the best ones to know when or how to make a change in your intake process. For example, if you want to educate more staff on the intake scripting process tool, or if you discover some statement that works better than what's listed in the HIS tool. Just document what was changed and then share your lessons learned at the group meetings. Consider, though, that others may have had similar experience and discovered a solution. And you may decide to just wait to make any changes so that you can discuss it as a group before you make that change. Second point here is that this tool does not track time from referral to first visit. You might want to do that internally. We'd strongly encourage you to do that to ensure that patients are getting services timely and to make an impact on readmission rates, as we discussed earlier. Third, always include your internal staff in planning and process, and customers even, if possible. Keep them informed of any and all changes in the process as well as results. And then fourth, celebrate. This includes both wins and efforts. No one loses when we all work together. If the results are not as expected, just celebrate the lessons learned and how you can use that data to improve care, implementation, and coordination. Remember that rewards can be for progress and efforts. Staff should always be rewarded for efforts, no matter the outcome. Last point is to learn together and to have fun. If this intervention is portrayed positively, it will be received positively by staff and clients. If you present it as a burden, it will likely be perceived as a burden. Our Superior Health Quality Alliance Care Coordination Team is ready and willing to help you make the most out of these tools by working together to resolve any issues, discover any new methods, and improve the health of your patients so they can live better lives. Barb Link and I, Lisa Gall, are available for any questions related to the use of this video, as well as the home care intake scripting tool and the home care acceptance tracking tools. Here are the links to the His and Hat tools with an example tool that's pre-populated, which you can review and play with and document in to practice prior to implementation. If you are interested in joining in any of the Superior Health Quality Alliance initiatives, just go to our website or contact one of us. Our member organizations across 4 states contribute locally to the national health quality goals through quality improvement initiatives. Our member organizations include the End-Stage Renal Disease Network, hospital associations, and quality improvement organizations and quality innovation network. Just visit our website to learn about Medicare initiatives in Illinois, Michigan, Minnesota, and Wisconsin. We also invite you to join the rich conversations and access great resources through Superior Health Connect. This is a shared learning environment for participants to foster and promote an all teach, all learn climate, which provides the framework to improve and sustain mutual healthcare quality improvement initiatives locally, regionally, and nationally. We are always looking for participants for projects. If you're interested in participating, just contact Barb or Lisa. Here's a list of the resources used in our presentation. Thank you so much for your interest in Superior Health Quality Care, Quality Alliance, Care Coordination, Home Care Workgroup Team, as we aim to make people's lives better by improving timeliness of home care services. This concludes our video presentation.